He's into soccer, basketball, flag football.
Ooh, I like it.
I played a little baseball in college. My ex-wife played for Oregon State soccer, so she's
So she's pushing soccer then.
She's pushing soccer. He gave up on baseball 2 years ago. Broke my heart.
Well, he's like at the right age that he like can then enjoy it now. Like he can turn it back because I did the same thing. So I I quit baseball. I quit like soccer and baseball, and then I did like a year off, right at that time where you're like 11, 12, and then you get back and you're like, oh, I actually enjoy this again.
Yeah. I guess for baseball, because everything like the other sports that he plays now, like just constant movement, running, right? I mean, I get the whole baseball thing, and that's why it's really tough to capture youth now in this technology age, because they're used to things just moving so fast, right?
Put him in like shortstop or second base. Like they are the ones that move all the time. That's what I played.
And I was middle infield as well. Yeah. And I guess it's a tough one because there's a lot of thought. I mean, you know this, right? You're always moving, but like at that age, like I don't think they understand. Like you got to back up every throw from the catcher to the pitcher. Like you got to be moving. Runners on base, balls hit. You're going somewhere. They just don't get that. They're like, oh, if the ball's not hit to me, it's like, what do I do?
That's why, I feel like the perfect position to play for like an ADHD kid is either short, second, or catcher, because then you're involved in every single play, and then you get like the glory of throwing people out.
Absolutely.
So like
even pitcher you can put in there too, because they're constantly throwing the ball.
I was never like tall enough, or like like the prototypical pitcher, whatever you like, the ones that are like, you're 13 years old, you're like already 6'5", like there's something wrong with you.
Right. You got these arms that hang down to your knees, and you can just whip the ball. Yeah.
And like they somehow like throw them like 80 miles an hour at Pee-wee, and you're like, not okay.
Yeah.
I have no idea how to get anything. So do you think he's ever gonna go back?
I don't know. He's not interested.
You just gotta convince him. That's when you like start showing the
Derek Jeter highlight reel.
Yeah, exactly.
Did you grow up in Washington?
I didn't. So I grew up. My dad was in the Air Force.
Okay.
And so I was born in Arkansas. We spent some time in Oklahoma, Texas, overseas in Europe, and then settled down in Florida whenever I was like 7. So that's mainly where I consider home.
So Jacksonville area?
So he was out of. So he was technically out of Fort Pierce, but we lived. So he was out. I think it was Jackson. And we lived in Daytona Beach area.
Oh, okay, so a little bit further south.
Yeah.
I know. So I grew up in Connecticut. My parents now there's.
It's like a hotbed for baseball now.
Yeah.
Especially like Little League stuff.
Yeah. They kind of became snowbirds like 3 years ago, and so they spent about 9 months in Jacksonville.
Okay.
But I see, we go down to the beach and we see all the. I guess there's a huge. I don't know if it's just Navy or combo.
So it's Navy and Air Force there.
Okay.
So Navy, Air Force on the East Coast, Navy on the West Coast. There's not a ton of Army in Florida, ironically.
I guess that makes sense. They'd be training with the gators in the swamps.
I don't know how to get that. Whatever. I'll figure out. Drew's gonna like walk in and press one thing, and he's gonna be like, "This is what you need to do." I'm like, "Done." Yeah. So it's like. Growing up there, like soccer was huge. So me and my brothers, and I'm not vertically gifted. So soccer and baseball were ideal choices. And I'm not like, my dad is like 150, 160, like soft and wet. Like he's the exact same build as me. So he played like cornerback in high school. And then whenever I was growing up, I was like, yeah, I don't want to be hit like repetitively at my weight, because like one of my best friends, he was a running back, and he was like the easiest of gainers. Like he ate like a protein bar, and he like gained 5 pounds of muscle.
Yeah.
And so like he was like walking around at like 15 like this, and here I come like, hey guys,
just little.
Don't want to hit.
Yeah.
So I never played football, but man, baseball and soccer were the best. I did ran cross country too.
Okay.
What position so you played center midfield? Central midfield? Or central infield? Duh.
Yeah.
Like crossing my sports right now.
Yeah. Middle infield, short second primarily. Was your dad a pilot?
So he was not. So he was a family practitioner in the Air Force.
Okay.
So he went to the Air Force Academy. He was a pilot for a period of time before I was born, and then they paid for him through the previous GI Bill to go to medical school. And then he went to med school and just stayed in the military for 21, 25 years.
Yeah.
And then he retired. When did he retire? 2000?
Okay.
So.
Yeah, I mean, you do your, whatever, 20, 25 years in the military, and so.
Yeah.
My ex's brother-in-law was a Navy pilot, and he retired at like 49.
Yeah.
He now owns the Chick-fil-A franchise that just opened in Northgate.
Ah.
So that's kind of like their new gig, and brought in family and, to do HR and, all this other stuff.
Nice.
So they're kind of, it's now a family business.
Good morning.
Good morning.
I have a food delivery for Deborah White or Debbie White.
I don't know her name, but I know it's one of the people that's here.
Okay, I will give her a call.
You don't happen to know that gal Sarah, who just signed on with Northwest Allergy? Do you know her last name by chance?
Let me look. I should probably know that. I think I have her in my phone as.
I'm doing the same thing. She gave me her cell a couple of weeks ago, but I don't have her last name. But I know she's been here every week, so I can ask her.
Don't.
Okay.
Good morning. I appreciated your email.
Good. I went over your notes and made a couple of word changes here and there, but they were very good.
Thanks, sir.
Thorough. Yeah, so that woman, we picked up some autoimmune markers.
Mm-hmm.
As I said, that doesn't mean to me she's got those diseases.
Mm-hmm.
They're just, you see that about half the time in people with chronic hives. You just look for it.
Which makes sense.
Did Drew give you guys an assignment of who's responsible for this week by week?
I think we're playing it by ear.
Yeah?
I think we're kind of cycling through. It's a pretty intuitive system. The problem with it is they can't figure out how to get that thing off the left side of the screen.
Is Drew in the building?
He's on his way in.
Okay.
He's gonna walk in, he's gonna press like one button and fix it.
Room like this when you got here, or someone set it up?
The room was like this when I got here.
Even though you said you're playing it by ear, somebody knows to come.
Yes, oh yeah, all of us. So usually we're all getting here by 6:30. I got here early, so we're kind of like going. I think I was just trying to figure out my way the first time.
Yeah.
And then we're kind of like going week by week where.
I mean, not everybody has to be here at 6:30 as long as you make assignments amongst the three of you.
That's the plan, at least right now. Check Zoom's.
You heading down to the Allergy Forum this weekend?
Friday.
You're gonna go down Friday?
Mm-hmm.
Yeah.
I don't, there's nothing happening on Friday except.
No, it's just registration, I think, between 5 and 7, from my understanding. But we'll
Yeah.
have, me and my Portland counterpart will have a new Nucala booth down there, and we'll
Yeah,
bring
they were
in
gonna-
Tom
They invited me to some meeting they wanted to have.
Nucala.
Yeah.
Is this with Tom or with somebody else?
What's Tom's last name?
Tom Klusenak, he's our
Yeah, I think
medical science liaison.
but they're gonna start it at 4 o'clock and I'm not gonna be there,
Okay.
so.
We are broadcasting.
We are?
Mm-hmm.
Did you communicate that to Tom, or do you want
I
me to?
didn't, no,
You did?
I got an email
Okay.
from him yesterday.
Okay.
My wife's gonna go, we have family that live down there.
Oh, okay. Nice.
A couple of guys who work for Nike.
Yeah.
Want some coffee?
I might have a half a cup.
Okay.
Thank you. So how many clinic days are you doing now these days?
There we go.
Huh?
I figured it out.
Okay, good. It varies, usually at least 3 a week.
Yeah.
Considering, I just turned 75, I'm still working a fair amount.
I think that's fantastic.
Yeah, I do too, I'd be bored otherwise, I have to teach guys like this.
Right?
I know, as we make more mistakes than we actually fix patients.
No, actually, I
I
love to teach people.
I really enjoy
And my,
working with you.
and my job is easier actually, because they write the notes, all I have to do is edit them. And the charting is, you know, the worst part of the job for all of us. Seeing the
Yeah.
patients, interacting with people and helping them is what is, what we enjoy.
Yeah.
Good morning.
Morning.
Morning,
Ian's
morning.
here.
Morning, Todd.
How you doing it? Set up. Receptor.
Thank you so much.
Recycle a tree.
I like it.
We'll save a branch.
And to Portland?
Yeah,
Week?
yeah.
Yeah.
Maine's far away, but I don't know why they're having a meeting there.
Then
I'm joking.
Palm Springs would be better, but
It's too close to the Village Mar. Or Mar-a-Lago or whatever it's called.
Mar-a-Lago, yeah, there you go.
How's your Alaska trip?
It was great.
Did you get some decent weather?
No.
Rain?
Yeah. It rained.
Is it cold up there yet? Colder than?
Yeah, it was 31 going through the mountains on Thursday.
Summer is definitely over.
I think so.
Yeah.
I was
The
hoping for
worst
it.
part is how dark it is in the morning.
Yeah. It's gonna rain in summer, maybe a good couple weeks.
Yeah. Well, last 2 mornings here, I've had frost on the car.
Yeah.
I'm in Renton up on the hill.
Yeah, this global warming thing is a hoax.
Yeah.
Yeah,
Makes
seriously.
you wonder.
This has been the coldest summer of my 13 years in the Northwest, for sure. I mean, I was thinking, I've already turned the heat on during the day, and I probably put the air conditioning on once this summer. Just never got really, really hot.
Who has air conditioning?
Yeah, I was gonna say, where do you live? 'Cause
You don't have AC?
we don't have AC.
We have
gosh,
the lowest
you gotta get it.
percentage of buildings that are AC in the country.
Yeah.
Yeah, maybe Anchorage.
Yeah.
I think Anchorage is in the country.
That might be
It's been
debatable.
gone the last 3 weeks. Trust me, last week I would have rather have been here than in Florida. Yeah. Oh, I feel like these last couple of weeks, everybody's been meeting.
We not have any hand.
Oh, I didn't look in there for handouts.
How'd you fix it?
I went through the admin side and I took it off the screen from the administration side. I don't know if I'm gonna break something by doing that, but
Probably.
worth a try.
Mail also.
Your partner retired. After
Yeah, you were here.
You guys hired?
No, we didn't have to about the huge one, so I don't think, well, it's like, we have to make some decisions.
Corporate reorg.
Yeah. Which is weird, because they're mandated to be kind of mirror what we
Yeah.
are, you know.
Yeah.
But it's, they're just, it's a territory.
Actually, I go for the opposite respiratory weekend.
Yeah.
I think they're gonna expand this for next year, but it's probably gonna be mostly just on the dermatology side.
Yeah.
Their derm reps are, one derm territory is the size of like two concentric
Okay.
Humira territories.
Really?
Yeah. Their derm reps are spreading really, really thin. And they're not
I think the waiver wire is gonna be pretty thin this week.
I know, that's what I'm realizing right now.
Are they calling on primary care?
I have Devontae Adams. That was my first pick, and now his toes hurt.
So
So
for
do
the
I.
biologic care.
I don't know what to do with him.
I mean, he had a really good week. They're saying his MRI came back
Negative?
fairly clean, so, I mean, he's got 10 days off. Played that Thursday night game.
Mm-hmm.
I'm hoping.
Same here. Are you making your decisions now?
I'm
Today's
placing my waiver.
Today's waiver night,
Okay.
so if you wanna add or drop anybody, today's usually the day in the leagues to do it.
The unfortunate thing, my strategy has been to pick up the defense that's playing against Miami
Alright.
every single week, regardless.
I
They're on
saw
a bye week this week, so I can't do that.
Who's next, man?
That's what I'm trying to figure out right now.
Okay.
It's been a winning strategy. Like each week,
Uh-huh.
I've gotten like 10 points because Miami's not very good.
I was reading something, so they are
Oh, I have it.
2 yards per game off, so they're giving up 249 yards, or the difference between their offense and the other team's offense is 249 yards. And it's the highest since 99 when the Browns came in the league,
Oh.
I was
as a,
at one of those meetings in Florida all last
what do they
week.
call that?
So
Oh,
really
okay.
check my personal
Yeah.
email.
when a new
About
team
that.
comes in the league.
How are you?
The expansion.
Yeah.
Much better?
Yeah.
The crazy thing is like, so they're bad. So like, when you look like the points
Yeah, you're pretty
differential,
sick,
it's
yeah.
like
Awful.
Miami has been outscored like 180 to like 20.
Yeah.
It is one of like the most staggering things, and they've thrown like more, they've had more turnovers
Smooth morning here.
than any team so far in
What's
the
that?
first 4 games.
So far,
That's
it's
why
been
like my
smooth
strategy
morning.
has been really successful, just like keep
Just
dropping the
Should
defense.
go that way the
Because
whole
I mean, like
time.
I'll drop like good defenses. I'll just be like, I don't care
I
about
think
like
it's-
the Rams or the Bears. I'm just like, I'm going for whoever's playing Miami
Yeah.
because they're gonna give me more points than any other team.
We got-
It's a position you
finally got
definitely
the
stream
system.
based on
Good.
matchups. You don't have to be loyal to a single defense all year. Unless you
So
have.
talk to
Wayne
Nicole at all?
who's done awesome.
Huh?
I had New England to start the year and I dropped them like right after the Miami game and I was like, there was a fluke, they're not gonna be that good. And then they've been that good, I was like, well, that was probably not a good decision.
Now they haven't given up a passing touchdown all year so far.
Oh, you did?
Yeah.
Yeah, she come in?
The Seahawks just give up their first.
Everett off.
Oh, cool.
Yeah,
Seattle's
yeah.
defense has been
Statistically, they're
Yeah.
really good too. so.
Yeah.
Did you see any moves?
She told me her.
Not this time.
Actual.
It's usually the highlight of my trip, my drive around place.
Really?
Oh, wow.
Good morning, good morning.
Wow.
Good morning.
Good morning. He's doing
What a
great.
day.
Good morning.
He's doing, he can come.
Hey, how you?
Hey, how you doing,
How
man?
you doing?
I'm waiting for the all Bears.
The only, I haven't seen any in my travels, we did do a fishing trip up on the Prussian River,
Oh, yeah.
which is on that way, on the way to Kenai. They ran, mom and a baby ran through the.
Oh, was it?
Morning. Oh, God, it was wonderful.
Yeah.
I was
Really
just,
good.
I've never seen it.
Hey there.
How you doing?
I'm good.
Good.
That's a good word.
She's different aloha shirt every week.
I try. I got a lot of them.
Oh,
Crashing.
No, I've seen it open these days. The old days, I would have been. I didn't sit there.
Oh.
I did once, I got told to move. I was like, no.
Yeah.
He wasn't even there that week.
You still working
Run
for
to
Everett?
work.
Clinic?
Well, I have some dates in December. I don't have any right away. They got their new film.
Oh, they got
Oh my
some.
God.
Well, they got.
I'm supposed to see pictures more than I've ever seen. Yeah, I know, but I'm not sure enough to deal with stupid things. My last email, I deleted it, which I made.
Already
Still in a little
Actually,
bit,
it's
but
So I got the one for.
just a reminder.
Yeah.
On the right? Yeah.
You're in Vermont.
Sorry.
I'm glad at least it
It's like
All this
pretty
noise.
intuitive.
not
Better?
when it's, not when it's busy and then quiet, unless they fixed it.
Oh, no, it misbehaves.
You had to ask for that.
Oh, right here, for sure. I didn't see that. She sent it to me in children's. So I had to like, and I've been
Surprising how few Seattle docs are gonna be in Arizona registration.
Yeah. Are not, yeah.
Oh, I keep it because,
You're not, you're not supposed to.
One half a sandwich.
Coach doesn't have one. They're the sports.
Would it be a family?
UW.
Smart. I have my shopping list for next weekend.
Judy free?
Yeah.
We'll see you there.
Yeah.
Maybe I'll be at the meeting, so.
I'll probably be calling anchors last week.
Seriously,
Those guys don't come down.
If it went
No, no, they won't.
Yeah,
Word.
all that.
it's all good.
Yeah.
Yeah, sorry. I feel like the reception in here is a little,
Yeah, it's not good.
it's one bar.
How's Ross? I'm just visiting today, but. You've been good.
I like this one.
Where are you now?
California.
Yeah.
Yeah, I have a shopping
Nice to
list
see you. I
this
had
weekend.
no idea you were gonna walk in the door.
I told you.
What? Yeah.
Good morning. How are you doing?
How have you been?
Not
too bad. Still walking, talking? Oh, yeah. Are you still driving a Tesla or are you?
Yeah, I've only got 50,000 miles on it. We take a big trip to Albuquerque.
What do you retired now?
I did a little part-time work for the Everett Clinic this summer. Paul McBride asked me to come back. But for the most part, I'm retired now.
How you enjoy reserve?
Pretty well. The golfing's not getting really much better, but I'm playing more, so.
You look good. You haven't changed at all.
Not much. Pretty good. I had a.
Oh, you are my best
I can walk with that one. So things are holding up pretty well.
Oh, yeah.
Looks great.
Yeah. Did you only eat half of that
I'm
sandwich?
just working it.
Dr. Kennedy, who did your surgery?
So they need better.
Uh,
You know anybody in there?
It's so bad.
Neil,
So,
Roberts?
dog.
Swedish.
One of the Swedish guys here up on the hill?
Sounds very George.
Yeah.
Yeah, Tinkle.
No, but it's not like micronaphia, like.
No, it's all right. Yeah, he's
Do a couple
the guy just recently joined the group up there. I'd seen
Here we go.
a couple of the foot guys there before, but never
I know.
seen the idea.
I want to be there, but.
Anti-anxiety, mother.
I was over at, I know most of those guys, I came over from the diffuse synthese sports medicine side.
like
Some
Martin.
arthritis injections, and now I'm doing Luthala on their GSK.
No.
It's not a super common
Well, I mean, you
procedure.
have different reps.
No, it's not, but it is definitely, I mean,
Were you a runner?
Given you said I'm not supposed
well, I
to
have
say
been a
this
runner in the
out
past,
of my
but
head,
I trained
thinking
lots
of
playing
making
soccer.
a this,
Yeah.
I did a lot of running for
Toes are out of time.
No, I know, but I've thought that many times, because, you know, even if he loses it, like, even if he loses it, like he was usually, you know, it's, yeah. Who called?
The guy who's in jail.
Oh, okay, yeah, if he refuses to leave, it's because he's gonna have an army coup or
So,
something.
yeah, military.
And it was great, he just lost, have to do a recount, blah, 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 whatever, it's not so crazy.
I think it's just
So I hope he makes it get so hot for him, he won't retire, he's gotta have to save face somehow. So I don't know how he does it, because he's worked himself into such a hole, you know, just crazy.
What's not him, he's already, you know what he is.
Yeah, he's a malevolent narcissist, but it was crazy, I mean, he's just,
How much, what's the time?
well, I know, because they're afraid of not being reelected because of their base is the political game. But there's one James McConnell who said, recently said, because there was some talk that he wouldn't even allow this vote to come to the floor. He said, well, we have no choice, it has to come to the floor, he's already shifting.
He's also the
Oh, we're gonna stop it.
Yeah, right.
Maybe Romney can actually lead a few people.
Yeah.
We have some.
Yeah, exactly. Romney's okay.
Good.
What am I gonna tell my family? What did I do?
I know.
What's funny is.
living the dream.
You know, this is personal, but I think about that, I think about global climate and all that.
I'm so confused.
Not around.
Be around 20 years.
Yeah.
I can't. There's nothing I can do,
You have to see the end of this in your lifetime.
if possible, yeah. So make it happen.
Dr. McBride.
Is this your baby? Yeah. We're all sharing it. so-
Yeah, I was,
This is the best part.
I just couldn't sense, yeah.
We don't have a
I love
keep it
how
going
he's
anymore.
I know, he told me all
I
about
wonder
it.
if you
I
can
know.
get just that.
Depressing.
Well, the rest of the time, you have to
Depressing.
be depressed.
Well, I know.
I mean, imagine
not
where
happy
the
about
country
that.
would be without the New York Times.
He's doing the
Yeah,
surfing now, he doesn't
exactly.
care.
What?
Oh,
Repressed.
I'm gonna see him tomorrow.
Yeah.
It's never been more valuable.
There you go.
$75 car tab fee, oh my God. Okay.
I bring the two papers, yeah, I just get them as I'm walking out the door. I wasn't gonna buy this yet, I saw how much it costs to get it delivered, and I thought, well, I think somebody's gotta keep the paperwork alive,
Yeah.
because it's
But,
dying.
you know,
Yeah.
Raiden,
Negative, D positive.
Unfortunate.
and
As a
Raiden
library,
thought,
as their books.
he thought
I realized the books above my desk at work, I haven't opened one of them in about 2 years.
Yeah.
Time to
Doing relatively okay, but now he's like.
sell them to
Desatting.
This is the chip, what is that?
Yeah.
Is that the universe?
We're gonna, like, do that.
The moon
it's
south
like
pole?
real deal.
Conversations.
I think he, I don't know how long it
Thanks for sharing.
takes. I don't know how long it
Italian festival.
It was great.
Oh,
Next year.
I'm sitting there, I'm like, oh,
congratulations.
Oh, thank you, yeah.
Oh,
Left
I
and right.
forgot, you have a new edition?
Yeah, no, two more, probably since I realized that it's in the water, apparently.
Okay, good to stay away from you and your
Yeah, I know.
family.
Another good reason to drink coffee. That's
Yeah,
the risk
yeah.
of gallstones.
That's right, I knew it. I was just busy with this work. Exactly. How things are you?
Is that right, Dr. Brown?
What's that?
See new babies?
Yeah.
Oh, I was just showing you
Yeah.
the,
Is that right?
yeah, we were in meeting last week.
Wow, exactly. Yeah.
That's good. Staying busy.
Congratulations, I heard you, program director.
Kind of. I'm doing more.
No, it's good. Sister's smothering.
What are you in town for?
So you pick them up, you.
How long are you in town?
Till tomorrow.
Tomorrow?
Where are you staying?
It's locked up my handbag, where are you?
Yeah.
I feel like I'm gonna need to take a look.
I do it like a bunch of girls. How's your week going there?
Yeah, no.
Okay, I'll give it
Got a
back to
bunch
you.
of stuff to do, but I did a lot of it yesterday. This weekend was Festa Italiana and my
Use every
cocktail,
But.
which I worked at. And I do a quiz every year. So that was very successful.
Oh, yeah.
Stuff like that, and then I've got a new student, I tutor kids pro bono who have special needs, mostly high school. So I have a new student coming, so they have an exam.
It's really burned as it falls into a hot pot.
You know I love her.
Just walking out there in the dark with no flashlight, fell into the guy's. How much do you believe of that?
Email or,
Week's been good.
personal or work?
Watching kiddo soccer on Saturdays and
How old?
go to school in Sammamish. He's part of the.
Oh,
Yeah, sorry about that. They're already starting to get organized.
Yeah, well, the third one.
Told you guys,
It works, yeah, check this.
You work on this function fine.
Yeah.
Hard thing is, so
Every single day.
That was pretty good. I love that. Right after 5:30 was first.
Oh, yeah.
It's nice, I can.
So we like, I was having like. Is it just the ones that,
Yeah.
I had to go through the admin side.
Gives me an opportunity to catch up with them. We talked a little bit about. So they'll be.
Sorry, I'm not.
As needed, kind of.
You gotta work.
Yeah, we have a meeting in the morning.
That way it does not seem to feel.
I heard you took the water.
Yeah, that's literally how I feel when I take the bus.
It is.
Now you know my life.
You shouldn't really take them out.
My wife and I would always say,
You know, it's fun that they're.
I showed you this side this year.
Just mixing it up, huh? Mix it up.
You know what I mean?
Oregon.
It's one of those like visiting roles, where it's like over
Yeah.
X days and then that.
Yeah.
It'll be a while kind of.
For a visit
Trying to think about that. When I talked to my parents, so they go from Connecticut to Jacksonville.
Oh, yes, I would tell.
Yeah. My mom's
I don't think it's just.
So.
Yeah, Billy, you're interviewing.
So they, you know,
Good point.
Hey, let's settle down here.
That's me,
I don't have any significant announcements. Anybody in the room got anything of importance? Yeah, I'm gonna do that in just a second. Anybody from the beginning of the year who didn't get to introduce themselves, who's new to the community, you'll be speaking, so that'll take care of that. So, we've got a visitor in the room, one of our former fellows, just shocked me when he walked in the room, June Liu. June, when did you graduate from here?
2011.
2011.
Wow.
So,
I know.
and you've come back to do more fellowship?
Sometimes I feel like I want to.
You're a glutton for punishment?
That's right.
All righty. Word of the day is receptor. I keep forgetting week after week to announce that, and then people write emails to me as to what was the word of the day, which I don't remember.
Thank you, Drew, for last week.
Yeah, so everybody who needed CME credit got their word of the day. So Anna is going to present,
Len?
yes,
Just one request, because they don't put it in the emails anymore.
yeah,
Maybe have it be at the last slide too, in case somebody joins late. I'm
Yeah.
sure Francis is sick of getting emails.
okay, that's a good idea. I think I'll tell Francis
Yeah,
to
yeah.
do that. Is Francis coming this morning for this meeting? No?
Probably, yeah, in an hour.
Yeah, okay. So remind me to tell her. That's a good idea, because then we won't get as many emails requesting it. So we've got to talk today about basically patent receptor, really the innate immune system. I don't know about the rest of you who learned immunology decades ago like I did. There was no innate immune system then, right? Everything was just cells and immunoglobulins. Obviously, there was an innate immune system. We just didn't know about it. And I can remember the first year I went to the academy meeting and heard about TLR receptors, and I sort of said, are they something new? I haven't heard about them before. So we're going to hear more about them this morning, right?
Oh. That you?
Is that you?
Nope.
You should say yes.
Yeah.
Right.
Nobody can tell, just say yes.
Sorry. Another one.
Remember that scene from Ghostbusters? Oh, yes, if you're a god, just say yes.
Thank you.
People that work in office or,
Great.
no.
All right, so for those who haven't met me yet, my name is Ania Lang. I go by Ania. And I just recently joined the group here at UW as clinical assistant professor. And I just finished my fellowship at the University of Wisconsin in Madison earlier this year. So, me.
Speak louder.
Okay. And so, so the topic of the talk is really focused on innate immunity, but a specific focus on the pattern recognition receptors signaling and how defects in the signaling pathway manifest as immunodeficiency. I don't have any disclosures to report. So the objectives of this talk will be to first do a broad review of the innate immune system, and then specifically review pattern recognition receptors and their signaling pathways, and then spend some time going over primary immunodeficiencies that are due to defects in toll-like receptor signaling pathways and NF-kappa B signaling pathways, which is very relevant to toll-like receptor signaling. And finish with a brief overview of disorders associated with mutations in other pattern recognition receptors.
Where did the term toll-like receptors come from?
I'll get to that in a second.
That's another decade.
So the innate immune system, its big role is that it's the early responder to pathogens and also cell injury. And so looking at the timing on the immune response is here on the right. They can be divided into immediate within literally immediately after exposure to within a few hours, followed by the next several days after an injury or infection, where that's when the inflammatory response is mounted by the innate immune system, and that is critical to then be able to have an adaptive immune response that develops from day 4 after. The innate immune system is interesting in a way that it has a relatively limited number of receptors, and those are called the pattern recognition receptors. But they are able to detect a very wide variety of danger signals, and that they do this by recognizing components that are common to them. And those are referred to as PAMPs, so pathogen-associated molecular patterns, or DAMPs, which are the danger-associated molecular patterns. And very broadly, the 2 main types of responses that innate immune system is able to mount are inflammatory and then specifically antiviral responses. Currently, we divide the innate immune system into 3 major parts. So first one is epithelial barriers, and we are learning more and more about them, and we're learning how critical they are to immunity. So they function by providing mechanical barrier through tight junctions and also ciliary function. But also they do make a number of chemicals which do have antimicrobial properties, including some of the fatty acids. They also can provide defense by providing low pH and also production of defensins. And we are also learning more about the importance of microbiota, and that's actually now considered part of the epithelial barrier and part of the important to innate immunity. The second big component are blood proteins, and those are primarily complement proteins, and I won't be spending much time on them today, but just to briefly review, complement is one of those, is a series of proteins that is able to respond to cell infection or cell injury immediately by either opsonizing the pathogens, recruiting phagocytic cells, or in some cases leading to direct cell lysis. And finally, a big part of the innate immune system are various types of immune cells, including phagocytes, dendritic cells, also mast cells, NK cells, innate lymphoid cells. So this is taken from Abbas and just a review of what kind of signals the innate immunity receptors respond to. So for the PAMPs, or pathogen-associated molecular patterns, they recognize nucleic acids from both viruses and bacteria, so double-stranded, single-stranded RNA, CpG, unmethylated DNA from viruses, bacteria. They recognize common patterns in a number of proteins in many pathogens, so like, for example, flagellin in bacteria. They also recognize common pattern in cell wall lipids, such as LPS for gram-negative bacteria, or lipoteichoic acid from gram-positive bacteria. They also recognize carbohydrates, such as through the mannan, which can be present in some fungi and bacteria. In terms of the damage-associated molecular proteins, patterns, they recognize things like heat shock proteins, and then components of mitochondria, nuclear proteins, which should not normally be there. Now, in terms of pattern recognition receptors, there's many of them, and some of them are cell-associated, some of them are in the cytosol, some of them are soluble. So here in the box are the toll-like receptors, which is what I'll be focusing on, and so I'll describe more about them shortly. But in the same category of cell-associated receptors, we also have other ones, which I'll touch upon later, including node-like receptors, which are present in the cytosol of the cells, Rig-like receptors, also in the cytosol, cytosolic DNA sensors, and C-type lectin-like receptors, such as dectins. In terms of Soluble receptors, they include pentraxins, which one of them is CRP, C-reactive protein, colectins, such as mannose binding lectin, and of course complement, probably most notably. So in terms of toll-like receptors, they are a series of proteins with a structure and function that is evolutionarily preserved. And so it was initially discovered in Drosophila, and the reason why it was called toll, well, actually I'm not sure that's the reason, but initially it was discovered as an important protein regulating the dorsal-ventral development of the fly. But then they also discovered that flies defective, or that they were deficient in this receptor, were susceptible to fungal infections. So subsequently, receptors with similar structure were found across the species. In terms of humans and mice, which is, of course, we study mice a lot to understand humans, toll-like receptors 1 through 9 are conserved. Actually, I apologize. For the TR10, there's actually been there's been some recent work. So it used to believe to be non-functional, but now it's actually known to be functioning slightly different than the other toll-like receptors, in that it's more involved in anti-inflammatory responses rather than multi-inflammatory responses. And then there's other toll-like receptors, 11, 12, and 13, which have been found in species other than humans. So here's the structure of the toll-like receptors. So it has a ligand binding site on the cell surface side, which has this classic leucine-rich repeat, then has a transmembrane domain, and then the signaling domain is the TIR domain on the cytosolic side. And this TIR domain, which stands for toll IL-1 receptor, it's a domain found in several other receptors, in all the homologs of IL-1 receptor, including IL-18 receptor and IL-33 receptor. Now on the right is shown dimers, so TLRs dimerize. Most of them form homodimers, so that's TLR3, 4, 5, 7, 8, and 9, but some of them form heterodimers. So TLR2 forms heterodimer with TLR1 and 6. And there are just some examples of these. For example, on the left, TLR1 and 2 heterodimer, and in the receptor, its ligand, the triacylated lipopeptide. So in terms of what cells express TLRs, they are really broadly expressed, but the patterns differ among different cell types. So monocytes and macrophages, which are really the key cells of the immune system, express all toll-like receptors with the exception of TLR3. Notably, plasmacytoid dendritic cells, which really specialize in mounting antiviral responses, are predominantly expressing TLR7 and 9. But toll-like receptor expression has also been discovered on other cell types like mast cells, B cells, and T cells, as well as on fibroblasts, epithelial cells, and some parenchymal cells. So this is a review of different ligands that toll-like receptors recognize, and then it really covers a wide breadth of pathogens. So here in brown are ligands for TLR2 and 6, and they're critical for recognition of di- and triacylated lipoproteins from mycoplasma, as well as other bacteria. TLR2 recognizes components of the gram-positive bacteria, like lipoteichoic acid. It also plays a role in recognition of lipoarabinomannan from mycobacteria, and also is able to recognize patterns from fungi and several viral envelope proteins. TLR4 it recognizes LPS from negative bacteria, gram-negative bacteria. Now, as you can see, so I just went over receptors that are on the cell surface. TLR3, 7, 8, and 9 are localized in the endosome. And they specialize in recognizing viral single-stranded RNA and double-stranded RNA. And in terms of TLR9, they recognize viral and bacterial unmethylated DNA. Another very important protein to toll-like receptor signaling is UNC93B1. It's an ER chaperone protein, and it's critical to deliver the endosomal toll-like receptors to the endosome. So without it, they can't get there. So in terms of signaling, I'll go through it step by step. But all these receptors have some common components of their signaling pathways. So after recognition of the ligand, they all require adapter molecules to then proceed with downstream signaling. And MyD88 is the adapter molecule that is used by all of them. The one exception is TLR3, and it requires this molecule called TRIF. So these are adapter molecules which then allow downstream signaling. In terms of TLR4, there's also additional adapter molecules on the cell surface, MD2 and CD14, which are necessary to allow binding of LPS. Now,
It's like a very stupid system. Because if they all use the same receptor, if you're deficient in that, they all fail.
Right.
You would think nature would have evolved it differently.
Is that a loop mutation?
It's just a philosophical comment. How do the intracellular TLRs, how do they meet up with their ligand? They're all viruses that penetrate the cell and enter the cell, as opposed to pathogens that would be extracellular?
That's right. Yeah, so they are, yes.
Did I miss it? Did you tell us how the name toll-like receptor changed to
Oh.
It's with the word of the day, then.
receptor?
So it has to do with the fact that it has to do with the dorsal ventral development of the fly. So I guess I have to double check, but I think it has to do with the fact that it's just the length of the fly. So it's tallness.
I don't know the answer, but I'm not sure it comes from English. I think it may come from another
They were
language.
German. I think it was German.
Oh.
Yeah.
Is a MyD88 mutation a lethal mutation for mice? Because that's
So-
Lynn's question. I mean, they all signal through that.
Yeah.
So you'd think if you knock out MyD88, then the mice would just die.
Even humans
So-
would die.
Oh, yeah, but I don't think we knock it out in humans, so.
I'll actually go through that a little bit later.
Aren't there humans where it is
There
deficient?
are, and are they alive?
What's the clinical presentation of humans that are?
Pyogenic infections.
Huh?
Pyogenic infections, are you on?
Yep, it's coming up.
We're stealing her thunder.
I will, yes, I will. But so once this MyD88 and TRIF are important in the upstream part of the signaling. I'll go through the next step in a bit, but down the line, what the signaling leads to is a series of inflammatory response, either through activation of NF-kappa B or AP1, or for some receptors, initiation of interferon responsive interferon response factors in antiviral response. So some common things to keep in mind about toll-like receptor signaling. Again, all except TLR3 signal through MyD88, and their primary result is activation of NF-kappa. TLR4 actually uses both MyD88 and TRIF, so it's a little bit different. And so through these two arms of the pathway can activate both NF-kappa B and also IRF3. And then TLR7 and TLR8 is signaled through MyD88 dependent, TRIF independent pathway, which can also activate both NF-kappa B and IRFs. So this is a big, I'll go through step by step, but in terms of defects in red are mutations that have been found to be defective and actually that have been clinically significant and found that patients who have these defects have been described. So I'll go through them in order. So the first thing I want to focus is actually the MyD88 as well as IRAK4 deficiencies. So again, MyD88 is very important for signaling for most of the toll-like receptors, and then IRAK4 is a kinase that gets activated following activation of MyD88 dependent TLR signaling, eventually leading to signal cascade leading to translocation of NF-kappa B and initiation of pro-inflammatory cytokines. So, like Dr. Altman pointed out, this really has a very broad effect on ability of many of these TLRs to signal. So the mutations that have been found in living patients are autosomal recessive. And these are very rare. In this review here, they described in 49 patients with IRAK4 deficiency and 22 patients with this autosomal recessive MyD88 deficiency. And we already went over what signaling pathways are affected. In addition to affecting TLR signaling, these mutations also affect signaling through IL-1 receptor, and also through this TRAP-dependent TLR4 signaling, so very broad effects. And then in terms of clinical presentations of this autosomal recessive mutations, it's very severe infections, but the spectrum of infections is surprisingly narrow, with primarily pyogenic infections with Streptococcus pneumonia, Staph aureus, Pseudomonas aeruginosa. The table on the right shows the kinds of infections that patients present with, meningitis, sepsis, arthritis, osteomyelitis, they have abscesses, pneumonias, ENT infections. These patients usually present by 2 years of age, and severity of infections actually decreases with time if they survive childhood. A bit more details on this is here. So a review of incidence of invasive pyogenic infections for IRAK4 and MyD88 patients with these mutations. So the graph on the left shows incidence of invasive infections versus age in months, and you can see that by about 35, 36 months of age, all these patients have developed some invasive pyogenic infection. The same for MyD88, but looking at survival on the bottom graph, the same age scale on the bottom, patients with IRAK4 mutations, the majority of them, most of mortality occurs in the first 40 months. And then on the right side, looking at age, past early childhood, there is not an increase in mortality. So it's a little bit curious how those mutations affect clinical course. One thing.
That's supposed to say 40 years at the bottom?
It is years. So on the left side it's months, and the right side is years.
There's the theory that adaptive immunity kicks in, and that's why these patients, if they make it till age 5.
Right. Yeah, and another thing that I came across, and this was just the one review, but one's idea was that these patients may have low frequency of these IgM positive, IgD positive, CD27 positive B cells, which are important in T-independent IgM antibacterial responses, which then become less critical as T-independent IgG repertoire becomes more mature in adolescence. That's
Does the adaptive immune system use either IRAC4 or MIghty88? Is it just the innate immune system?
It's not directly, but it is involved in signaling from IL-1 receptor. So it's important in any inflammatory response, including those activated by adaptive immune system. In terms of management, it's really focused on immunizations against the relevant pathogens, prophylactic antibiotics, and then in some cases, if patients have defects in specific antibody production, IVIG, and of course, a quick treatment of any suspected infection. So now, the next group of mutations affecting TLR signaling and have been described in patients are mutations in the above, so TLR3, and I group them with the other ones because they do have they have similar clinical outcomes. So mutations in UNC93B1, which is this ER chaperone necessary for delivery of the endosomal TLRs, as well as mutations in TRIF, TRAF3, and TBK1. And so looking at where they are in here, so TLR, so these all these proteins are important in signaling cascade initiating from TLR3 stimulation, but also in signaling through the TLR4 TRIF TRIF-dependent signaling. And so, again, they'll be expected to result primarily in severe decrease in type 1 interferon production, and that's the case. But curiously, clinically, the patients with these mutations are uniquely susceptible to HSV1 encephalitis, but they don't have frequent infections in other, it doesn't seem to affect host defense against HSV1 or other viruses outside of the CNS. And so these mutations are relatively rare, autosomal recessive in case of UNC93B1. Again, patients usually present between in early in life, and they do have recurrent HSV1 encephalitis. No other systemic or cutaneous HSV1 dissemination, no other severe viral infections. They do tolerate other live vaccines. And some of the mechanistic studies looked at production of type 1 interference in response to TLR3, 7, 8, and 9 in vitro, and they found defects, but for some reason this pathway appears to be redundant in vivo, at least in case of these autosomal recessive mutations.
What's so unique about that one virus? I mean, that's the only thing that they're prone to?
It's not known. It's very similar for the TRIF mutation, so like in the same cascade. It's the tear domain attachment molecule for TLR3 and for TLR4. These are extremely rare, and both autosomal dominant and autosomal recessive mutations have been described. And again, the only clinical correlate was HSV1 encephalitis, and this was associated with defects in fibroblast production of type 1 interferon. And then TLR3 mutations, several different types have been described in patients. The most common are autosomal dominant. Some are compound heterozygous. And Again, there is no answer right now as to why HSV-1 encephalitis is the main presentation, but in the case of TLR3 mutations, they did find some differences in which cell types were affected in their ability to produce type 1 interference with stimulation to HSV. So in this case, only fibroblasts were affected, but peripheral blood mononuclear cells were not. This might potentially explain why these patients are able to mount other antiviral responses.
You know how or why that's dominant?
I'm sorry?
You know why or how that mutation is dominant in its effect? Not a inherited, not like, it requires 2 molecules to make it. I guess it's just sort of a...
Right. Good question. Yeah, I don't know because.
Would it be more of a dominant negative effect?
I mean, that's presumably
Right.
Right. That you just don't have a sufficient amount of body.
I think so.
Usually think of this being an excess that you are.
Right, because it's homodimer, so it would have to be dominant negative to. Sorry.
Is it a homodimer? I didn't think it. I don't know.
TLR3 is a homodimer. I mean, management is really treatment of infections and supportive care. And then I want to spend a bit of time about mutations affecting the canonical NF-kappa B activation pathway, which is again critical to inability of toll-like receptor signaling to exert its effect. And so mutations have been described in several components of this pathway. And those include mutations in NEMO, as well as I-kappa B alpha, as well as NF-kappa B1. So to review the canonical pathway of NF-kappa B activation, on the left side is the pathway working correctly. So following stimulation, for example, through toll-like receptors, eventually it leads to activation of I-kappa, IKK, gamma, or NEMO kinase. And this is an essential modulator of NF-kappa B. Once it's activated, it then phosphorylates the downstream I-kappa B alpha, which at steady state, it is binding the NF-kappa B dimer, preventing it from translocating to the nucleus. So following phosphorylation of A-kappa B alpha by NEMO, it then leads to a release of the dimer so that it can translocate to the nucleus and signal. And again, mutations affecting this pathway have been described in patients that involve several different types of NEMO mutations, as well as mutations in I-kappa B alpha, and also mutations in the NF-kappa B1 component of NF-kappa B. And as you can imagine, these mutations don't only affect TLR signaling, since they're involved in many different pathways. For pattern recognition receptor signaling pathways, they also affect null-like receptor signaling, RIG1 receptor signaling. In adaptive immune response, they affect signaling through T cell and B cell receptors and CD40. And they're also important in developmental pathways, including development of ectoderm through and osteoclasts. So several different mutations have been described. For NEMO mutations, they are X-linked recessive, and so they are hypomorphic, associated with decrease in normal gene function, and more than 30 different types of 30 different mutations were described. For I-kappa B alpha mutations, they are autosomal dominant, so hypermorphic, associated with increase in normal gene function. So clinical presentation is variable, but in terms of susceptibility to infections, it's compared to MyD88 and IRAK4, because activation of NF-kappa B is a critical downstream event through pathways using MyD88 and IRAK4. But so with NEMO and these ICA-Kappa mutations, they have much broader infectious susceptibility, although it still involves pyogenic bacteria in many cases, but also infection by fungi, also susceptibility to mycobacterial infections, and some viruses. In terms of types of infections, they are, I think, often invasive infections, like meningitis, pneumonia, and sepsis with bacteremia. Oh.
I'm just curious, maybe no one's ever studied this. These are very rare diseases, and I wonder if they're rare because the vast majority of defects just lead to abortion and or fetal death. And anybody ever studied premature aborted fetuses to see if they carry these genetic defects? And one of the reasons that you have a high spontaneous abortion rate in humans.
Did not come across that. I don't know if anybody else has. But I think it's these are obviously critical components of immunity and development. So I think there's probably like other mutations are probably compatible with life.
They lead to morphogenesis abnormalities as well, like toll-like receptors, which has to do with ventral or maybe anatomical other things going beyond infection.
That's right. In terms of the susceptibility to mycobacteria, so the NEMO mutations are associated with a specific type of MSMD, or the Mendelian susceptibility to mycobacterial diseases. There's a number, so to briefly review that MSMD is a condition that can be caused by a number of different mutations that disrupt this signaling pathway between mycobacteria infected monocytes and T cells. So normally infection with a mycobacterium would lead to production of IL-12 by monocyte, which would then lead to activation of T lymphocyte, which would then produce interferon gamma, further propagating the cycle and also leading to destruction of the infected cell. And for mutations have been described in interferon gamma receptor, STAT1, IL-12 receptor, but in leading to MSMD. In case of NEMO mutation, it's also involved in part of this pathway. Specifically, it's important for CD40-mediated IL-12 production by monocytes. So this is a specific type of MSMD associated with NEMO mutations. In terms of clinical presentation, so it's not just infections. Patients often have colitis, inflammatory bowel-like disease with colitis and diarrhea. NEMO mutations are also associated with ectodermal dysplasia with immunodeficiency. And so shown here is one of the presentations of it, which can be involved, which can have like, thin hair, hypodontia, hypohidrosis. In females who have partial immunodeficiency, which is X-linked dominant, they may have similar findings, including rashes and also other similar features similar to ectodermal dysplasia. Now, there's a number of immune abnormalities associated with these mutations, including hypogammaglobulinemia, a reduced specific antibody response due to impaired CD40-mediated B-cell class switch recombination. These patients, they are not uniformly found in all patients, but some can have elevated IgM or IgA level. They can have poor responses to polysaccharide vaccines and poor NK cell function. And then mutations in one of the dimers of NF-kappa B and NFKB1 have been associated with CBAV-like phenotype, and this can have very variable presentation, but includes hypogammaglobulinemia, frequent sinopulmonary infections, bronchiectasis, autoimmune cytopenias, inflammatory bowel disease. It can also be associated with skin cancer, adenocarcinoma, adrenal insufficiency. So very broad effects on that mutation. And in terms of management, so again, it's case dependent. It may involve IVIG if there are defects in specific antibody production, antimicrobial prophylaxis, vaccination, and then hematopoietic stem cell transplant is can have variable outcomes, and it has high associated morbidity. Now, there have been, so these are really the major mutations that have been clinically recognized affecting the TLRs or TLR signaling. There have been a lot of different single nucleotide polymorphisms in TLRs that have been in case studies or small case series found to have to be associated with infection susceptibility. So, for example, TLR2, some SNPs in TLR2 are associated with asymptomatic bacteriuria in women, maybe associated with CMV infection in liver transplant patients, and also associated with susceptibility to mycobacterial infections such as leprosy and tuberculosis. Now TLR3, again, some other associations with viral infections have been found, but they are really in this very small number of patients and not reproducible. But in some case studies found association of some SNPs in TLR3 with hepatitis B and C infections. And then there was this one cohort study in Spain where they actually found that patients with certain polymorphisms had resistance to HIV infection, but that has not been seen anywhere else. In terms of TLR4 mutations, so polymorphisms have been associated with infection, with increased incidence of sepsis, with gram-negative bacteria, RSV bronchiolitis, disseminated candidiasis. And for TLR5, one polymorphism is specifically associated with susceptibility to Legionella infection, as well as impaired IL-1 response to flagellum and increased risk of UTIs in Caucasian women. And there are other polymorphisms that have been described. I have not included them all.
Or the ones you're putting in bold, the ones, I mean,
so
a lot of this has been just debunked, and I think there's a lot of controversy over how real any of this may be, right? Because there have been these weak associations, a lot of bias studies. Do you have a sense, reading the literature currently, how much of this is validated or well believed versus not?
So I think the ones I put in bold, I felt that they were the strongest ones. I included the other ones because there has been a lot of others, like it has been described, but I didn't feel that it was a very strong evidence for that. And then defects, now looking at it from the other angle, patients who do have other immunodeficiencies can have defects in TLR signaling. So that's the case with patients with CDID, chronic granulomatous disease, XLA, hyper IgE syndromes, and also ADA deficiency. So that's something to keep in mind. In terms of evaluation, there's TLR assay done by ARAP, and so which can assess response to specific toll-like receptors based on stimulation, based on in vitro stimulation with their specific ligands, and then they do a multiplex speed assay and they detect cytokine production in response to specific ligands. So specifically, they measure IL-1 beta, IL-6, and TNF alpha production. And then for a measure of TLR3 function, they measure CXCL10. And then there's also genetic testing available, either immunodeficiency panels, such as the one we have here at Seattle Children's, or custom panels if you have a high suspicion for a specific mutation.
So the TLR assay, I mean, I think it's worth noting that even the company itself says it really has practically no diagnostic value. I mean, I've ordered it a couple of, I mean, I'm not dismissing what you're saying here, but it's not really something you should order until the very last resort, because, so it was developed by Jordan Orange based on pre-chemo patients. And it will pick up Nemo, but it's unclear if it will pick up anything else. And it just has really no sensitivity and specificity. The guys at ARUP reviewed like 20, well, it was developed in 2006, so however many years ago, but a decade worth of data, and showed that it had maybe picked up like 2 patients in that whole time. Just shown at CIS several years ago. So, you know, I don't know, it's just worth pointing that out. This is not a test you should advertise necessarily.
I mean, sort of following the axiom, you should never order a test unless you're going to do something with the data. Why would you ever order it? What are you going to do with the information?
Well, it is worth knowing, if you have a kid with a true TLR defect, which I don't think has ever been described in the US, you would want to know, because it will manage how you determine how you treat them.
My case had 3.
What's that?
My case had 3.
Yeah, okay, all right, so it is in the US.
Yeah, it's in the US, but it's very rare, like you're saying.
But in terms of, you know, we often think of, I mean, the reason is because, again, it was developed on Nemo, so you have to have a pretty severe defect. They measure 3 cytokines in response to different TLRs. And you get a lot of sort of intermediary results that you don't really know. And if you do truly suspect TLR defect, you should do it.
Because I guess even with,
But can you fix it?
Yeah, you give them IVIG and hypovaccinate them stuff until they're older. So identifying if you really
Probably do that even without the data.
I mean, I guess the obvious question is, how do you get false positives? I mean, if you truly had a defect, are there other mechanisms where you'd produce these lymphokines?
Right. Well, so
there must be.
The shipping, so you have to always send a shipping control.
Right.
And even with that, you can oftentimes get false positives where you just have, you know, more production.
Yeah, we had one patient where we sent it twice, and TLR3 was low both times, but his presentation otherwise was inconsistent, so we didn't think it was real. Yeah.
just very
I
technically
think all the
test.
people who do the Iraq 1988 patients in Europe, right, they just, I think John Laurent has to spend all the killer, they just doing the sequences. So it's just a problematic aspect.
Thanks much. Okay, so I just want to finish up by going through a few other pattern recognition receptors that don't necessarily correlate with infections, but I think it would be important to review for completeness. And so that would include the C-lectin-like receptors, which recognize fungal polysaccharides, leading to, again, NF-kappa B activation. And also point out that the other pattern recognition receptors, like node-like receptors, and RIG1 helicases and MDA5 are associated, mutations in those that have been described in patients are associated with different clinical outcomes. So additionally, there's also mutations in node-like receptors include NLRP3, which is part of inflammasome, and mutations, and that have also been described with, which affect generation of active IL-1 and inflammatory response. So for dectin-1 mutations, these are the it's a C-lectin type receptor on the cell surface. Autosomal recessive mutations have been described. They have variable penetrance, and they have high prevalence of heterozygosity, up to 8% in Europeans, and they're higher in sub-Saharan populations. And then this is associated with defects in beta-glucan recognition and susceptibility to mucocutaneous candidiasis. And then similar clinical presentation occurs with autosomal recessive mutations in CARD9, which is adapter molecule for dectin 1 and 2. They also have increased susceptibility to fungal infections and defects in Th17 signaling. In terms of node mutation, I just wanted to point out, it's not something I think we're going to see clinically often, but mutations in this receptor are associated. There's two different types of mutations. One of them, mutation in the C-terminal domain, is associated with Crohn's disease, as well as impaired mucosal antimicrobial defense with decrease in defense production. Whereas mutation on the N-terminal of the node 2 is associated with Blau syndrome, and its autosomal dominant is actually increased with basal NF-kappa B activity. And I think I also included these mutations do come up on fellows' board reviews, so something to similarly, mutations in RIG1 helicase and MDA, pattern recognition receptors are associated with interferonopathies, and two different types are described. The first syndrome, Aicardi-Gutierrez syndrome, second, Singleton-Merten. Again, not something I expect we see clinically often, but these mutations are associated with elevated levels of type 1 interferon. And finally,
there are now also mutations, right, in loss of function of MDA5, I think, right? Because that is severe rhinovirus.
I didn't see that. And defects in NLRP3, which is the cryopyrin gene, are autosomal dominant with variable penetrance, and those are associated with autoinflammatory syndromes, or CAPS, cryopyrin-associated periodic syndromes, like familial cold autoinflammatory syndrome, Muckle-Wells, and then NOMID. So, I mean, in summary, this is a generalization, but I just want to, by pointing out that pattern recognition receptors of innate immunity are important in generating inflammatory and antiviral responses, and their defects in some, as we just described, are associated with increased risk of infections, but there's also disorders leading to actually increased inflammation, either inflammation or interferonopathy associated with mutations in these other receptors, like node 2, NLRP3, and then RIG and MDA5.
Mutation.
Okay.
All right.
Yep.
Thank you, Ania. I just wanted to add that around 3 to 4 years ago, there was a new mutation in STING protein. That's an intracellular DNA sensor, and that's a syndrome called Savy Syndrome. Children with this defect present with extensive vasculopathy and lung disease. They typically present to rheumatology, and this was described at the board review course 3 years ago by Jordan Orange when I was taking boards. And it's important for the fellows to understand the new defects, especially the things that have been described in the past 2 years. So it's called Savy Syndrome. So that's that's another pattern recognition receptor.
I think the rule is once it's been in the literature for 2 to 3 years or more, it's fair game for it.
Thank goodness we don't have to take
They looked at some of these viral infections where there's a wide range of clinical manifestation, like West Nile, or just a very small tip at the encephalitis.
Is that related
Could there be
to
some
TLRs?
defects in the signaling? Then the people with Eastern equine encephalitis or West Nile, the ones that are most sick are you're picking up a defect.
I did not come across that.
So what was the question, whether
Is
for those other viral infections, if they're associated with TLR deficiencies?
If patient with susceptibility, like say susceptibility to West Nile virus infection, if there is no defect that leads to that.
I think that's been exactly the problem with this research into single nucleotide polymorphisms with TLRs, right? TLR, there was all this excitement, I don't know, 10 or more, once we understood how they worked, that all these polymorphisms would tell us about what mycobacterial diseases like tuberculosis, viral diseases. And as I understand it, I think Tom Hahn has sort of talked to me most about this, most of that has proven non-reproducible, no real mechanisms behind it. There's been some associative studies, but none of it really. That's why I asked about your previous slide, which is what is actually believed. Because there's a lot of false literature out there around that topic.
Yes.
There's a few diseases that keep showing up on your list, like meningitis, legionnaires, mucocutaneous candidiasis. How many of these infections do you think people need to have before you pull the trigger on a genetic workup? Like, it seems like everybody with meningitis should get an immunodeficiency workup even after one event. I mean, I don't know if
true.
I got the wrong message from this talk,
No,
but
that's exactly right. There's actually a very good paper making that statistical argument, saying that anybody who has bacterial meningitis in the absence of a very clear risk factor, so like an army in the military in a buff where there's an outbreak or something, warrants a workup because more than 10% of those will have a primary deficiency. But not only like diseases like this, but complement deficiency and otherwise you need to think about.
it just seems like some of these infections are relatively common, like legionnaires, it's not really common, but we see it quite regularly. And I just wonder if these are people that we should be screening as soon as they get those infections.
Again, I think if it's an outbreak in a community, like Legionnaires.
Other than an outbreak where it's a source.
Group, but yeah, if you just had a random case of Legionnaires, I would work that up.
How many patients with these collective defects do we have locally, or followed locally?
One.
Okay. We have a girl.
Anybody take care of any of them?
We have a girl who's undergone 2 transplants.
For what?
She's got I kappa kappa, alpha, I can't remember which one. Which means Alex will, which means that Alex will be very upset with me. But yeah, no, we've had one girl, she's in Montana, who transplanted twice. First transplant was complicated by disseminated MAC.
And there have been multiple chemos in the area. I mean, that's
Yeah,
probably, my guess is that's the most common of everything we have listed here.
And short of vaccination and IVIG, do we have any other choices other than bone marrow transplant for these people?
Not right now. Yeah.
So identifying them is crucial, but treatment options are still quite limited.
Right.
So again, I mean, it depends, like, MIT-888 and Iraq-4, which is sort of the paradigm that's so popular in the study, if you bridge these kids for several years, then they're fine thereafter, right? So if you can just take care of them in the first 5 years of life with antibiotics, IVIG, hypervaccination, they live a normal life. Which is why those in particular, I don't know if that's the case with TLR3 as well, with the HSV encephalitis. So I would assume that they also become less at risk over time.
The case, maybe you see, the cases I've never seen in real life, but the cases I reviewed, it's very variable course. It can have a very severe infection early in life and then be okay for many years and then have recurrent like later. So, yeah.
And knowing what you
I mean,
know.
I think actually thinking on it, I think Casanova said you just keep them on lifelong acyclovir prophylaxis.
And do you tell these kids never to have kids? I mean, what's their recommendation? You
Oh,
keep
okay.
them alive all their life and then say, don't have any children?
Well, they're recessive, those ones, so actually their children will be fine if you have somebody with an Iraq-4.
them under, just you. I would see these, I'm glad I don't have to treat. Send them on the way to you.
Same computer.
They all end up with that chapter starting. They all end up with and 500. All the different responses.